The patient with diabetes mellitus. Dental professionals have a significant responsibility to recognize signs and symptoms of diabetes to promote early diagnosis in order to significantly reduce life-threatening complications of the disease and improve quality of life. Assess the management and control of diabetes to determine the impact on dental treatment and oral health of the patient. Work with the patient and other healthcare professionals to provide preventive oral care aimed at maintaining health and preventing infections and emergencies. Understanding the presence of infection, including periodontitis, may make it more difficult to control the blood glucose levels in diabetes. Identify and treat acute emergencies. Diabetes mellitus. The definition. Diabetes mellitus is a group of metabolic diseases associated with hyperglycemia or high blood glucose. Hyperglycemia results from an insulin deficiency, resistance to insulin action, or both. People with poorly controlled diabetes mellitus are at risk of complications including retinopathy, loss of vision, kidney failure, atherosclerotic cardiovascular disease, that is coronary heart disease, cerebral disease, stroke, and peripheral arterial disease. Peripheral neuropathy, nerve damage to extremities, and increased risk for amputation of toes, feet, and legs. Diabetes impact. Prediabetes prevalence. In the United States, 84.1 million adults, more than 1 in 3, have prediabetes. Nearly half of those aged 65 years and older have prediabetes. Prediabetes is similar among racial and ethnic groups. Diabetes mellitus prevalence. In the United States, 30.3 million adults have diabetes. Approximately 23 million people, or 1 in 4, with diabetes are undiagnosed. American Indian, Alaska Natives, non-Hispanic Blacks, and Hispanics have the highest prevalence of diabetes. The southern states and the Appalachian regions have the highest prevalence of diagnosed diabetes. 132,000 children and adolescents younger than age 18 had been diagnosed with diabetes. As the population ages and with increases in obesity, diabetes has become more prevalent. Medical costs and lost work and wages for those with diabetes are $245 billion annually in the United States. The risk of death is 50% higher for individuals with diabetes compared to those without diabetes. Globally, 415 million adults have diabetes. Health expenditures due to diabetes globally are estimated to be $673 billion. Oral health implications of diabetes mellitus. Infection that does not respond to treatment in our tissue that does not heal may be a sign of undiagnosed diabetes. Conducting a diabetes risk test may help to identify those patients needing referral to a primary care provider for evaluation and diagnosis. The relationship between diabetes and periodontal disease. The association of diabetes with periodontal disease is hypothesized to be related to the inflammatory process involved in the pathogenesis of both diseases. Diabetes as a risk factor for periodontitis. Systematic reviews suggest patients with diabetes are at a 2 to 4 times greater risk for more severe periodontal diseases than individuals without diabetes. The effect of periodontitis on glycemic control. Evidence indicates individuals with diabetes had more severe periodontal disease and a higher A1C than healthy individuals. The effect of periodontal treatment on diabetes. Non-surgical periodontal therapy and management of periodontal disease have resulted in an average increase in A1C of 0.36% to 0.46%. This is roughly equivalent to decrease seen in physical activity and weight loss intervention studies. Management of periodontitis along with lifestyle changes may have an additive effect in lowering A1C. Dental caries. There is conflicting evidence for a direct relationship between diabetes and risk for coronal or root caries, but there is a reduction in salivary flow and higher levels of dental biofilm, which puts the patients at risk for dental caries. Endodontic infections. Patients with diabetes have increased periodontal disease in teeth involved endodontically and have a reduced likelihood of success of root canal treatment. Dental implants. A meta-analysis found the failure rate for dental implants was similar between individuals with and without diabetes. The basics about insulin. Definition. Insulin is a hormone produced by beta cells in the pancreas. Insulin directly or indirectly affects every organ in the body. The description. The beta cells of the pancreas are responsible for releasing insulin when stimulated by nutrients, primarily glucose. Insulin acts like a key to unlock the cell to allow uptake of glucose to use as energy. The functions. The functions of insulin are listed below. Without the insulin, glucose accumulates in the blood, resulting in hyperglycemia, which in the long term results in damage to the cells and tissues throughout the body. Normal blood glucose levels in healthy individuals range from 60 to 99, and hemoglobin A1c is less than 5.6%. The effects of absolute insulin deficiency or type 1 diabetes. Glucose increases in the circulating blood, hyperglycemia, until a threshold is reached and glucose spills over into the urine, glycosuria. Increased glycosuria induces osmotic diuretics with excretion of large amounts of urine, polyuria, water and electrolytes are lost. Fluid loss signals excessive thirst to the brain, polydipsia. Cells starving for glucose may cause the patient to increase food intake, polyphagia, but weight loss may still occur. Without glucose to use for energy, the body metabolizes fat for energy. Energy products of fat metabolism are harmful ketones that accumulate in the blood. Ketones are acidic, and when they accumulate, they are usually neutralized in the blood. When large quantity of ketones are present, the neutralizing effect of blood is depleted rapidly. In an acidic condition, metabolic acidosis results. Metabolic acidosis, diabetic ketoacidosis, DKE, leads to diabetic coma if not treated promptly. The effects of impaired secretion or action of insulin. Type 2 diabetes. Deficient insulin action results from inadequate insulin secretion and or diminished tissue responses to insulin. Cell surface insulin receptors develop defects and glucose cannot be transmitted into the cells. Blood glucose levels increases as insulin resistance of the cells increases. This stimulates more insulin to be released. Over time, insulin secretion may also decline and lead to both decrease of insulin in the blood and increased insulin resistance of the cells. Insulin complications. Earlier diagnosis, improved treatment, and better informed patient, family, and friends have reduced the occurrence of emergency insulin complications. Constant verbal and visual contact needs to be maintained with the patient during treatment to identify early behavioral and physical changes indicative of developing a medical emergency. Hypoglycemia or insulin shock. Too much insulin. Hyperinsulinemia, which lowers the level of blood glucose. Hypoglycemia. Hypoglycemia is low blood glucose. It is an emergency, more likely to occur in dental settings for symptoms of hypoglycemia. Individuals with a longer duration of diabetes and history of severe hypoglycemia are more likely to experience hypoglycemic events. Hyperglycemic diabetic coma, ketoacidosis, too little insulin. Hypoinsulinemia with increased levels of blood glucose, hyperglycemia. Identification of individuals at risk for development of diabetes. Diabetes risk factors. Adults at risk for diabetes include those that are overweight with a body mass BMI greater than 25 and other risk factors such as physical inactivity, first-degree relatives with diabetes, high-risk race ethnicity such as African American, Hispanics, Native Americans, Asian, and Pacific Islanders. Women who have delivered a baby that weighs over 9 pounds or had gestational diabetes during pregnancy. Hypertension greater than 140/90 or taking antihypertensive medications. Women with polycystic ovarian syndrome. History of cardiovascular disease. A1C greater than 5.7%, impaired glucose tolerance or impaired fasting glucose. Prediabetes. Individuals who have blood glucose levels above normal but do not meet the criteria for diagnosis of diabetes are considered to have prediabetes. Prediabetes means the individual is at a high risk for developing diabetes and cardiovascular disease. The Diabetes Prevention Team, the DPP, showed a 58% reduction in progression to diabetes in those with prediabetes with lifestyle changes including modest weight loss of 7%, and a minimum of 150 minutes a week of physical activity. The most frequent medication used to manage blood glucose is metformin. Classifications of diabetes mellitus. Classification is based on the etiology of the disease. The type of diabetes is based on the circumstances and the time of diagnosis, such as gestational diabetes during pregnancy. Type 1 diabetes mellitus, the description. It accounts for 5 to 10% of those with diabetes. It results from the destruction of insulin-producing beta cells in the pancreas for one of the following reasons: autoantibodies or no known etiology. The result is an absolute insulin deficiency requiring exogenous insulin to sustain life. Patients are prone to ketoacidosis. It typically arises in childhood or adolescence, but may appear in adulthood depending on the rate of beta cell destruction. Individuals with type 1 diabetes are also prone to other autoimmune diseases, such as Graves' disease or Hashimoto thyroiditis. The former names: insulin-dependent diabetes mellitus, juvenile diabetes, or juvenile onset diabetes. Type 2 diabetes mellitus, the description. Most prevalent type of diabetes accounts for 90% to 95% of all patients with diabetes. Pancreatic insulin secretion may be low, normal, or even higher than normal, but the patient exhibits an insulin resistance that impairs the use of insulin. Onset typically occurs in adulthood, and the risk increases with age, obesity, and lack of physical activity. Although traditionally thought of as occurring in adults, the incidence has increased in children and adolescents due to increases in lack of physical activity, overabundance of fast food, and obesity. In children, the average age of onset is 13 years. Screening. Type 2 diabetes is usually identified after acute symptoms of hyperglycemia prompt evaluation. Screening in asymptomatic adults is recommended for prediabetes and type 2 diabetes. Basic criteria for testing in healthcare settings are the following: age 45 and above, repeated a minimum of 3 years. Screening begins earlier and more frequently if the patient is overweight or obese. When tests are normal, they are repeated at least every 3 years. Screening should be done in children and adolescents who are overweight and obese and have other risk factors for diabetes. The former names: non-insulin dependent diabetes mellitus or adult onset diabetes. Gestational diabetes. The prevalence of gestational diabetes mellitus, GDM, is a higher as 9.2% of pregnancies in the United States and as a high 15% worldwide. Defined as any degree of glucose intolerance first recognized during pregnancy. Onset is related to genetics, obesity, and hormones causing insulin resistance. Insulin adjustment, carefully supervised prenatal care, and improved obstetric practices have lessened much of the potential danger of for the mother. Infants are larger, premature births are more frequent, incidence of congenital malformations and perinatal death is high, and rates lower when improved prenatal care. More than 50% of women with GDM go on to develop type 2 diabetes within 5 to 10 years. Screening. Pregnant women with risk factors for diabetes should be screened at the initial prenatal visit. Women with no history of diabetes prior to pregnancy should be screened at 24 and 28 weeks of gestation. Women with gestational diabetes should have lifelong screening for diabetes and prediabetes. Other specific types of diabetes mellitus. Monogenic diabetes syndrome. Neonatal diabetes occurs before the age of 6 months and is typically of genetic origin. Maturity onset diabetes of the young typically occurs before the age of 25 years and is also related to genetic abnormalities in at least 13 genes. Cystic fibrosis-related diabetes occurs in 20% of adolescents and 40 to 50% of adults with cystic fibrosis. Insufficient production of insulin from the pancreas is the primary cause and is related to poor nutritional status, more severe inflammatory lung disease, and greater mortality. Post-transplantation of diabetes mellitus, PTDM, also called new onset diabetes after transplantation. And immunosuppressants and glucosteroid use post-transplant are the major causes of PTDM. The diagnosis of diabetes. Diabetes symptoms: polyphagia, excessive hunger; polydipsia, excessive thirst; polyuria, excessive urination. Diagnostic test: glycated hemoglobin assay, Hba1c or A1c. A1c measures the quantity of the end product of high glucose bound to a hemoglobin molecule, glycated or glycosylated hemoglobin. An easy way to remember this is to think of the red blood cell count as your donut and the product of high glucose as the glaze on your donut. The higher the level of the end product of the high glucose in the blood, the more glazed the donut, the red blood cells. A1c values provide an average of glycemia, blood glucose levels over a 3-month period. The Hba1c test is used to diagnose prediabetes and diabetes. Prediabetes is diagnosed with an A1c value of 5.7 to 6.4%. A1c greater than or equal to 6.5 is used to diagnose diabetes. The A1c is also used to monitor diabetes control. Testing is recommended twice a year for individuals with good glycemic control. Patients with unstable glycemic control may require testing every 3 months. A1c goal may vary slightly for an individual based on risk for hypoglycemia, but for the goal, the most non-pregnant adult is less than 7%. Individuals with a history of severe hypoglycemia may have a less stringent goal, such as less than 8%. Fasting plasma glucose. Measurement of fasting plasma glucose, FPG, is taken after fasting at least 8 hours and used for diagnosis in the following ways. FPG of 100 to 125 is used to diagnose prediabetes. FPG greater than 126 is the criterion used for diagnosis of diabetes. Repeat testing is recommended to confirm a diagnosis. 2-hour plasma glucose, typically measured during an oral glucose tolerance test. A 2-hour plasma glucose of 140 to 199 is also used to diagnose prediabetes. A 2-hour PG greater than 200 is used as a criterion for the basis for the diagnosis of diabetes. Repeat testing is recommended to confirm a diagnosis. Diabetic screening in the dental setting. Dental visits provide an opportunity to screen patients for undiagnosed diabetes. A type 2 diabetes risk test is available on the American Diabetes Association website and could be used chairside in the dental office for screening. Screening may also include point-of-care POC Hba1c testing using finger sticks or gingival crevicular bleeding. Standards of medical care for diabetes mellitus. Consideration is given to individuals' needs related to age, activities, vocation, lifestyle, knowledge, attitudes, personality, culture, emotional, and psychological needs, as well as the health and nutrition status and weight issue of the patient. Early diagnosis and management of prediabetes, diabetes self-management, education are significant. The interprofessional healthcare team, educational resources are also significant. Medical nutrition therapy, physical activity, and habits that should be eliminated are tobacco and alcohol. There are also psychosocial issues. The pharmacological therapy, insulin therapy. All patients with type 1 diabetes require exogenous insulin for survival. Type 2 diabetes patients may need to use insulin in combination with other medications for glycemic control. Type 1 of insulin. Types of insulin. Insulin is classified as rapid-acting, regular, short-acting, intermediate-acting, or long-acting based on the onset, peak, and duration of action. The doses. Objective. Attain optimum utilization of glucose throughout each 24 hours. Factors affecting need for insulin. Food intake, illness, stress, variations in exercise, or infections. Sick day rules. Insulin dose is adjusted if there are any factors that affect the need for insulin. Methods for insulin administration. Subcutaneous injection with syringe. Insulin pen. Continuous subcutaneous insulin infusion with a battery-operated insulin pump. Inhalable insulin. Anti-hyperglycemic therapy. The medications are listed below. The most common medication used in prediabetes is metformin. Monotherapy lifestyle management plus metformin, A1C less than 9%. Dual therapy lifestyle management plus metformin plus additional agent, A1C greater than or equal to 9%. Triple therapy lifestyle management plus metformin plus 2 additional agents, A1C greater than or equal to 10%. The takeaway message for dental professionals is that when a patient is multiple medications, it means that diabetes is not well controlled. Complications of diabetes: infection, neuropathy, nephropathy, retinopathy, cardiovascular disease, amputation, pregnancy complications, and medical health. The dental hygiene care plan. The control of oral infection is vital. Infections can progress more quickly and can alter the management of diabetes. Frequent, thorough oral care requires the patient operation along with regular professional care. The patient with diabetes is prone to life-threatening emergencies. Emergency practice drills can help the dental team prevent an emergency, identify early indications of developing emergency, and act swiftly and appropriately.